Welcome to Senadipan Education Foundation again. Imagination is more important than knowledge. Here we have an important person who has imagined above all of our imaginations. Before that, before going to the program, let me introduce the forum to you. Actually, Senadipan Education Foundation was launched in 2012 by releasing a set of educational DVDs by Professor Sion Han Kim in Trivandrum. After that, we started having fellowship programs, 6 months and 1 year fellowship program, which are hands-on programs in basic and advanced laparoscopy surgery. And then we started hands-on training. With the advent of COVID in July, we started online programs like webinars. And it was Professor Palanivedu who released the logo of
Or do you start?
Senadipan Education Foundation in July. Senadipan Education Foundation is an online platform. It used to conduct live surgeries in online platform. It did the first FB Live, Facebook Live program in April. We did a laparoscopic anterior section. And then in YouTube, we did a lab Bipul in August. A link was shared to the members of Senadipan Education Foundation. We conduct webinars with live lectures with world leaders in minimal access surgery and other surgeries. And we started giving e-certificates. And we have almost 10 WhatsApp group of Senadipan Education Foundation, almost full. And we have got a Facebook group. And in the season 1, we conducted 28 webinars with the stalwarts in the field of surgery. And we have got global acceptance. More than 56 countries participated. Many of the webinars, and the participation is more than 1,000 in most of the webinars. And we have a YouTube channel of Senadipan Education Foundation, and all the videos are visible for free in Senadipan Education Foundation YouTube channel. Now, today, it's a landmark event in the history of Senadipan Education Foundation. We have Prof.R.J.Heald, the creator himself, who revolutionized rectal cancer surgery. And Professor R.J.Heald and Basingstoke District Hospital are synonymous with TME, total mesorectal excision. And we religiously follow his dictum since 1982. Senadipan Education Foundation is really honored to have the creator himself, Professor R.J.Heald, in this forum. Let us give him an applause to welcome to this forum. Along with Professor R.J.Heald, we have Professor Mark Coleman and Dr. R.RAJESH.T.K. Professor Mark Coleman is a consultant surgeon in University Hospital of Plymouth, UK. He is the one who has popularized the colorectal surgery in UK, and he is lead consultant in 3 states of UK. And Professor Coleman will be introduced by Dr. R.RAJESH.T.K. R.RAJESH.T.K is my close friend. He is a consultant in colorectal surgery in Plymouth, United Kingdom. He is academic director and robotic surgeon, GEM Hospital, Chennai. He is the first Indian surgeon to do TME. He is a Royal College tutor too. He is the first batch to pass FRCS from India in 1998. He has got British Award for Best Paper 2009. He is trained in TME. He is a visiting consultant care, Newfield Hospital, UK. I'll hand over the mic to TK. Before that, let me ask the participant to mute their mic. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene in between talk. Everybody will be given permission to unmute their mic if they want to speak in between. If you are in a portable device, please mute your audio and hide your video. And please mute and hide your video if you are not in a casual dress event. And next webinar is by none other than Professor Alfred Kusheri, who is known as the father of modern laparoscopy surgery. It will be in Google Meet, not in Zoom, 7 p.m., 23rd of April, 2021. And you can contact me in senadhiban@gmail.com. I am handing over the mic to Rajesh.T.K to introduce Coleman, and Professor Coleman will be introducing our speaker, Professor R.J.Heald. Over to Dr. Rajesh.T.K.
Thank you, Baiju. Can you hear me?
Yeah, we can hear you.
Good morning, good afternoon, good evening to all my friends and colleagues from all over the world. I thank Baiju, my friend, the chairman of Senadhiban Education Foundation, for giving me a wonderful opportunity to take part in the exciting global event. As like everyone, I am also excited to listen to the talk by Professor Heald on Holy Plane of Heald. I work in University Hospitals of Plymouth as a consultant colorectal surgeon and had the opportunity to meet Professor 2 years back. I also worked with Professor Palnivelu in his fantastic hospital in Chennai as a visiting consultant, and I thank Professor Palnivelu, my chief, for teaching me these techniques. I met Baiju 10 years back in a conference as a faculty, and our friendship continued since then, as we believe in the same motto that giving need not always be material. A wish, a prayer, your time, or an idea is also giving. As you have seen during this COVID pandemic in the last year, we have listened to talks by great eminent speakers from all over the world. I thank all of them. After finishing my FRCS in 1998, I came to England, and I would say I was a second generation trainee of Professor Heald. I was trained by his registrar, Mr. Shanahan, for 4 years. I met Professor in 2008 in Pelican Cancer Foundation in Basingstoke, a great facility and a great training center. Next, I met Professor in 2018 and demonstrated trans-anal TME to Professor. As this saying, which says, if your actions inspire others to dream more, learn more, and do more, and become more, you are a leader. This saying is true for my great colleague, Professor Mark Coleman. I met Professor Coleman in 2011 and entered his LabCo training program, and subsequently appointed me to be his colleague. We were also selected for National TATME training program, which was the first of its kind in UK in 2017. Professor Coleman always comes out with great ideas. One of his ideas were Bowel Cancer West. Through this charity, many of our patients in Southwest were benefited. I have spoken to Mark also to help poor Indian patients who suffer from bowel cancer through his charity. Next idea is LabCo training program, and which is an international training program which has helped many fantastic colorectal surgeons to become trainers. LabCo program in UK also helps surgeons to become proficient in laparoscopic colorectal surgery. He also released a LabCo manual in 2017, which explains about everything about laparoscopic colorectal surgery, and also consultants becoming trainers. He took LabCo from UK to international standards, and he has won awards from America. This is a LabCo training program in Australia and in USA. He also made global and went to Europe and introduced the LabCo training programs in Denmark and in Poland. And this is his day-to-day activity as a consultant surgeon in University of Plymouth Hospitals. He's also chairman of JAG, a lead clinician in National Training Program LabCo, a chairman of External Affairs Association of Coloproctology of Great Britain and Ireland, a chairman of the Bowel Cancer West, chairman Plymouth Postgraduate Medical Center and Council, honorary senior lecturer, associate professor, fellow of the Faculty of Surgical Trainers, and member of RCS advisory group on robotic surgery. Now he has become a robotic train the trainer. And we will also allow Mark to come to India to train our colleagues who are best in laparoscopic colorectal surgery to become a best train the trainers. Over to you, Mark. Now you can introduce Professor Heald.
Are you viewing my slides?
No.
Can you see my slides?
Rajesh, can you stop your screen? Yeah, now we can see.
Thank you, and thank you very much for the kind and honourable invitation from Rajesh.T.K and Professor Baiju Senadipan to talk at this meeting. I'm sure we'd all like to just reflect for a moment as the UK is in a state of mourning over the sad loss of Prince Philip, Duke of Edinburgh. Turning to another great icon, Bill Heald. It's not often that you have the honor of meeting your great heroes. It's an even rarer honor for you to be trained by and get to know your heroes. And finally, the greatest honor is when you can call those great heroes your friends. And I am really honored to say that on all three fronts, I can put Bill Heald into that category of my life, having met him as my hero, being trained by him, and become his friend with myself and my family and his family. Now, I trained with Bill almost 25 years ago, and we've known each other before, during, and since. And there's no doubt that his reputation is that of a true heavyweight champion of colorectal cancer surgery. And he has an international reputation as a cancer surgeon. He's only one of a handful of living surgeons who have developed a new operative technique that definitively improves outcomes for cancer patients. In Professor Heald's case, he's devoted his professional lifetime to developing the operation of total mesorectal excision for rectal cancer. He was the first to appreciate that rectal cancer threatening the radial surgical resection margin was a major cause of local recurrence of disease following proctectomy. He appreciated that rectal cancer, as previously practiced, was being performed inadequately in the wrong anatomical plane, and that proctectomy should also include the anatomical mesorectum. The development of TME, or surgery in the holy plane, has single-handedly reduced the local recurrence rate of rectal cancer from 25%, in some cases higher in the early 80s, to below 5%, a reduction of 80% in the prevalence of one of the most difficult to treat sites of cancer recurrence in the body. He's also been director of surgery at the Pelican Cancer Foundation. He's had a personal chair of surgery at the University of Southampton. He is former vice president of the Council of the Royal College of Surgeons of England. He is past president of the section of coloproctology at the Royal Society of Medicine and of the Association of Coloproctology of Great Britain and Ireland. He has received numerous honorary degrees and professorships in Sweden, Holland, Switzerland, Israel, Italy, Germany, Poland, France, Austria, China, Serbia, and beyond. He has performed many hundreds of TME operations in many, many countries around the world, is extremely well traveled, and remains extremely active in teaching, training, and mentoring colorectal surgeons. And he's managed to do this from what has to be said, a small hospital in the grand scheme of things, the North Hampshire Hospital in Basingstoke. What people also maybe not appreciate is that he was instrumental in developing the Peritoneal Malignancy Institute in Basingstoke and the Pelican Cancer Foundation. This is now the highest volume unit in the world for the treatment of peritoneal malignancy, the highest volume unit in the world, yet another feather in the cap of Professor Heald. And of course, now he continues his work globally, but also as the director of colorectal research at the Champalimo Institute in Lisbon, Portugal, where he travels as frequently as possible, allowing for the constraints of the pandemic. And yet, despite all of this, you can see a photo of him there with Rajesh.T.K and my great colleague, Walter Dewey. I can pick up the phone and say, Bill, what are you doing next week? Can you come down and join us in the operating room, guide us, help us, give us your commentary when we're trying to implement new techniques such as total transanal TME. So thanks again to the team, Professor Baiju and Rajesh.T.K, for inviting me to moderate and introduce Bill Heald. And it's my enormous honor to now hand over to him for his talk on rectal cancer. And despite the audiovisual difficulties, I'm sure it'll be an experience that few will forget, as he always gives a great account of himself and his experience and his knowledge. Thank you, Bill. Over to
you. Thank you, Professor. Over to Professor Bill Heald.
It's a wonderful pleasure to be here. We've been having some very great difficulty with the color on the videos, which are the heart of my presentation. And I have a friend and colleague, a technical expert, who will now run the video we made especially for this only 2 days ago. I just hope that the video quality is good, because without it, I'm afraid my words may not mean quite what they should. But let us try. Technical problems in talking all this distance away usually seem to disappear. But on this occasion, I must say I'm very nervous about my talk, which was only made a few hours ago. But Nick, let's fire it.
Thank you so much, Baiju, and the Sanadipam Foundation in India for choosing such a lovely title for me. My Holy Plain couldn't be nearer my heart. It's really kept me going all my life. One of my more inspired moments long ago. My present home is the Champalamo Foundation in Lisbon, and my English home, the Pelican Cancer Foundation in Basingstoke. There's an aerial view of Champalamo on the mouth of the River Tejo in Lisbon, a beautiful, beautiful building. And there, Amjad Parve has built up a robotic surgery school, the European Academy, and we are looking every day at the water from which Bartholomew Diaz and Vasco da Gama sailed away and discovered your wonderful continent. So very exciting place to be. And you've given me the Holy Plain to talk about. It's probably the more important of the two original papers. The Mesorectum in Rectal Cancer, a case report of half a dozen cases, was probably the highest index, but TME, anyway, is an important concept. Whether you do it open, laparoscopically, robotically, or you're in the new group that does it from below by TAMIS TME. Well, these are the reflections of an aging voyeur, that's me. And I'm taking my inspiration from a great composer, Johannes Brahms, whose picture you see there. He took 20 years to compose his first symphony. And he described the inspiration as being like a gift. He took the idea and made it his own. And he said, without craftsmanship, inspiration is a mere reed shaken by the wind. I guess I've worked on the craftsmanship. I've done almost 600 cases in other people's operating rooms, apart from the ones I did in my own. Sweden, more than 100 visits, probably 100 to Germany now, and so on. So I've been all over the world with this idea. But things have stopped in the last few months, or last year. What's happened in rectal cancer? Horrible percentage of deaths compared with a fraction of 1% for non-COVID cases. If you operate on people, of course, it's selection really. But anyway, it's been a rotten time. Imaging has progressed, sequencing and immunotherapy and radiotherapy delivery all have developed in that period. We've had Rapido halfway through the year from Sweden, suggesting that short course plus time with chemo is better than 6 weeks of chemoradiotherapy, as most of us have tended to give. Exciting for me, only a few weeks ago, this lovely lady got in touch with me again. I've been following her for 13 years. She had a horrible rectal cancer. She had preoperative chemoradiotherapy, and I could not feel it when I arrived to do the case. 13 years later, she has had no operation. She is living a full life with horses and family and moving to France in a few months. It's exciting to remember that some patients with bad cancers do get complete responses. So please keep your finger ready to think twice about a complete or even possible complete response. Wait longer and give the person the chance of missing the surgery altogether. A little bit of history. Sir William Slack correlated damage to sexual function with the amount of nerve tissue he found on the outside of the specimen. And John Gallagher, who was there, both of these were personal friends of mine. John Gallagher said, if you haven't made the patient impotent, you probably haven't cured him of rectal cancer. Not true. The year I became a consultant surgeon, 1973, they were writing, you must excise the hypogastric plexuses to effect an adequate resection. Not true. It's a shame to set aside sexual function and impair other functions of the pelvis and the sphincters. So back to our inspiration for the day. Without craftsmanship, inspiration is but a reed shaken in the wind. I like the idea of all that and taking my holy plain idea and making it my own. What has not changed? Embryology. Exciting paper, rather odd paper actually, not sure you have to read it, but Calvin Coffey and I and others have written a paper about the fact that the organ is really the mesentery. And you can see if you go back far enough in embryology, you actually see the mesentery comes first and the gut develops within it. So the mesentery and gut are one organ. And happily for us, there's a plane all round it. There are envelopes, nice avascular planes, all down to embryology. Maybe our principal concern, the pretty girls are there just to keep me cheerful in talking to you, but the nerves of pelvic happiness are really very important. We know these diagrams, they're quite confusing, and all the names are there. The inferior mesenteric plexus is on the front of the aorta, the sympathetic hypogastric plexus within the aortic bifurcation, hypogastric nerves down the side walls, pelvic splanchnic nerves coming forward from the front of the sacral plexuses, and all things we want to save. We should note that huge variations occur in blood vessels, but less in the layers, which are much more predictable and reliable as anatomical guides to what we do. I believe planes are between layers. And the most important plane is the innermost dissectable one, the mesorectal fascia. So fascia is a realer tissue that you can dissect in. A plane is a potential avascular space created by dissection. We do have two extra layers which make my holy plane a little bit more complicated than it used to be at the beginning, because we have two layers, sometimes densely attached and always attached partly to the mesorectal package, Denonvilliers at the front and Valdaire at the back. And they are incomplete laterally, which has important implications for our dissections. This is a recording of a part of a dissection in Germany. It's only a few years ago, and it's with Jürgen Weitz from Dresden.
You can see that. And
just listen to the discussion.
I'm not sure how often the laparoscopic surgeon can do it quite with this amount of precision.
I can tell you my opinion about it.
Go on, tell us.
No, because to be honest, I've never seen it like this. Never. So.
I'm most enthusiastic about laparoscopy and fascinated and interested by it. But you see the two buttocks, Bill's buttocks? Okay. Well, in Holland, where I spent a lot of time before the Dutch trial, Bill's Billon.
So there you're looking at the two buttocks at the back.
It's a nice idea to go as far as you can at the back.
Here's actually the note.
So that seemed to us a very satisfying and pleasing dissection. And I show it to you to give you a little inspiration and to show you how you get beautiful specimens like that. How do you start? Well, here, let's go to laparoscopy. We'll try and touch on all the methods during my talk. And you see here, finding the pedicle package, identifying a shiny core specimen, the root of the core specimen. I think it's better to do this than to go immediately for the root of the artery and the vein. Let's have another look in a little bit closer. You just see how Professor Capescu from Bucharest, who I visited and did at CME as usual. And here you see looking for the shiny and finding that root. And there the superior rectal vein you see through. And here the holy plane, the start of the holy plane. Now this will take, this is a slightly older video and not quite the quality of the previous ones, but you see here, looking down into the pelvis, in a female, in a woman, lifting the ureter to the left. Again, you see just to the right of the dissecting plane, you see the superior rectal vein. And this essentially is the positive ID of the visceral envelope, the key of finding that shiny core to the whole dissection that makes for holy plane dissection and an optimal specimen. High ligations, the artery there, just clear of the pre-aortic nerve plexuses using the ligature. Note that you overlap those two ligature applications, and then you go for the division of convenience in open surgery. I've not been able to persuade anybody laparoscopically and then confirm pulsatile blood supply. If you've got pulsatile blood supply on the colon going down, you will be okay. And now getting into the pelvis. We start again there and go slowly, because you have to go slowly. We speeded this up. This whole case will take about 7 minutes total, but not at this speed. It would take an hour and a half or more at this speed, which is the real speed. We are just very carefully finding what we hope is the holy plane. It's got nothing to do with the peritoneal reflection itself. It's a question just of finding the best, innermost, dissectable plane, which is the holy plane. And it's around the midline structure, which is the gut. Gut with a midline blood supply from the front of the aorta. And we're going down into the pelvis. And this is an inspiration speeded up video to try to give you, as if you didn't already know, the idea that we are talking about separating a midline organ, the gut. You see it there, surrounded by areolar tissue. And you notice just a little practical point, whenever you're going to put your hand or a retractor, it's a good idea to use gauze to be gentle to the tissue. Again, you see that concept of a midline organ. You're looking at the back of the mesorectum, beginning to see the two buttocks. Here again, the concept of the midline organ, absolutely crucial. And there, Bill's buttocks, the two buttocks. But now the vagina is inclined to be a bloody thing at the back. You see there, you can so easily make it bleed. So you've got to keep clear of those vessels. And then when we come to the right side, you see the inferior hypogastric plexus. Important to save it in the woman. It's all to do with orgasm and, like in the man, potency. We'll see some more pictures of the holy plane and the inferior hypogastric plexus. Now we're getting right down in the depths, and you see, we're seeing all of the dissection on this case, but it's speeded up, and you see little squirts of blood where we've had to stop, of course. And only Amjad with his robot can do this without any bleeding at all. Here you see the anterior mesorectal fat. And the Denonvilliers septum, which we'll talk about in the man, is sometimes absent. I don't see really much sign of it in this woman. And often I don't find one in a woman. This is the front dissection, and now over on the left. As I say, you're seeing every bit of this dissection just speeded up. And therefore it looks a little bit bloody in places. It's not too bad, actually. But you see the ligature being used. And as we get lower and lower down, they're dividing a bit of the pubococcygeus muscle. And that was an open surgeon's trick to get into the very low anorectal region. Here you're seeing the plane between vagina and mesorectum and rectum. As we get lower and lower, the tapering mesorectum sometimes goes right into the puborectal sling. And you see there the puborectal sling very clearly wrapping around the anorectal muscle. And gradually we get to the Moore and triple stapling technique, where the first stapler is on and the division between two staplers, having washed out before putting the one on that's going to stay in the patient. The staple line should have been washed on the luminal side. And then we're looking at the specimen and we get Phil Quirk or someone to look at it. We look very carefully at that end to be sure that there's no cancer at that point. So that's the Moore and triple stapling technique.
So you'll see
just the very top
there.
We didn't really show the very top. We did.
There's a little vein there which is going to be unused,
dissection.
so we just touch it with the side of the valley lamp. Too many of those, you will certainly get retrograde ejaculation, and it's nice to leave the nerves behind and to follow the back of the pedicle package up in this way. You see the fourth part of the duodenum just isolating there. There's always a little window between the artery and the vein, and the little window is there. I have my finger round the back, you understand? You can see that, can't you? I have my finger round the back, and that is a big, thick inferior mesenteric up.
That's the top of the inferior mesenteric envelope there. And this is the first time I ever used a ligature. In the old days, you had to cut the sealed root of the inferior mesenteric artery. You notice we've carefully preserved the sympathetic nerves on the front of the aorta.
I go through that.
The first time I ever did that was in Stockholm.
I don't know what you think about that.
And I was quite excited that it seemed to work. It does work very well. So a little more inspiration. Just this is a more recent video of higher quality, and video quality is so very much the key to having the technique taught. The loving of the holy plane. You can see on this video, I hope you're getting it with the quality that I'm seeing it. And the traction and the counter traction are opening up the potential space. Remember, a plane is a potential space created by dissection. And you see, we're following that. It's got nothing to do with where the peritoneal reflection is. We're following the white, areolar plane, the cheveux d'ange, the angel's hair. And everywhere we're trying to open that potential space and then stroke our way gently into it. Amjad Parve with his robot, I'll show you some of that later. He always talks about it being like painting with the monopolar diathermy. Traction, counter traction, and most of all, cut only where you can see. And here I think in quite inspiring real plane between the midline gut and the surrounding parietal tissues. Stay in the white and you'll cure the cancer, except in those cases nowadays identified by MRI, where the mesorectal fascia, that's the layer above the white in this picture, the mesorectal fascia invaded by cancer. Well, of course, that patient gets chemo and radiotherapy before we tackle it, and the dissection becomes a little different. I'll show you a little bit of robotic holy plane dissection after radiotherapy later. But there you see the shiny surface, the traction.
I'm a little bit thick.
Now on the Chinese one, I want you to listen to the sound.
That is the right hypogastric nerve there. The inferior hypogastric plexus is rather close to and adherent to the mesorectum.
现在这个息肉进入这个切点分离，在直肠系膜跟它这个下部神经丛之间分离，这个地方就是我们大家所说的这个确认带部分，就是这个部分。
Are you recording, please, Ron?
所以确认带的解释，这个地方为什么经常被写到这个资料里面去写。
Considerable excitement in Wuhan, you can tell. They can see that this is a key moment of the dissection. it is dissecting carefully on the surface of the mesorectal fascia. I don't know how many of you have Chinese, but there you are. Now, jump from China to Heidelberg in Germany. Jürgen Weitz is helping me. And there, the inferior hypogastric plexus, damage that and or cut it, as was recommended, you remember, back in the 70s. And I think instead we should take passionate care to do mesorectal surface dissection, because there isn't really a holy plane here.
This is
And why not?
Because
this is what they used to call.
We used to call a ligament, but you don't see any ligament.
No ligament. Absolutely not. Now, Joël Leroy, who visited you recently, this is a moment when he won a bottle of champagne from me, because he and I had been friends for years, and I said when he got pictures of the inferior hypogastric plexus to compare with mine, I would buy him a bottle of champagne. This is how he won it.
You see, this is
I want a picture of that.
this
please.
is a urgent pillar. This is move back.
That is the sort of picture that
superior
brings you a
hypogastric
bottle of
plexus.
champagne.
This is superior hypogastric plexus and the branches of nerves. You see the danger, and I suppose it is what people said it was a lateral ligament in the past. And you have a lot of branches that are coming from the plexus, from the sacral branches.
Those are your
to
best
the rectum.
pictures so far, Joël. They
Please.
are very beautiful and it's magnificent. It shows the inferior hypogastric plexus there.
Okay.
The inferior hypogastric. So there we are. These planes, they can be seen, of course, on MRI. But before we leave Joël, I just record the fact that he declared himself determined to do exactly what I'd been doing open, to do it laparoscopically. And indeed, he clearly has succeeded. The principles are exactly the same, whether it's done laparoscopically. But now, of course, we do try to plan with the MRIs and decide which ones need pre-operative treatment. And I've changed my rules. I'm not going to read these things out, but essentially, life has become a little more complicated because Denonvilliers and Valdaire are best called septa or layers. I don't think they're fascia. To me, a fascia is a potential space created by my dissection, but that's a personal preference. But let's call the Denonvilliers called his layer an aponevrose, an aponeurosis. But anyway, let's call Valdaire also a septum. I don't like the word fascia for that because it's actually a layer. The positive idea of the visceral envelope and not the vessel root first, I've mentioned this already, and the innermost dissectable plane, then pursue it round the whole mesorectum. It applies in all kinds of dissection, laparoscopic, robotic, open, transanal. The two extra layers are white sheets, so they are layers. They're not fasciae, despite us calling them so. Denonvilliers described his in 1837 as an aponevrose pubio-rectale. And you see that he also called it the pubio-prostatique. And indeed it is. A nice picture there to show you that indeed it is a two-layer trapezoidal tapering down sheet on the front of the mesorectum, and it has a lateral limit, a lateral edge. Coming from above, it looks like this. This is one of my favorites. It's an open case, but you don't often see anything better robotically or laparoscopically, I don't think. It shows the lateral edge, it shows the back of the vesicles. This was in Aosta, with a lovely man, Umberto Parini, used to, we used to run, he'd do laparoscopic, I would do open, and we'd see which people preferred. Here you're seeing the more lateral, is actually no Denonvilliers there. It's actually the layer is the mesorectal fascia over fat. So it's just a very thin fascia there. These of the fused pictures are old, but they are just as good as any I've seen more recently. The U-shaped incision in Denonvillier's septum, and you see the fingers there. Open surgery has advantages. We can be sure we're getting beyond the tumor.
Cancer now, and Brendan is absolutely beautifully showing me where to go with his research. Doesn't matter in the least, if it does any harm.
So that's Denonvillier's septum, 2 layers. You see the 2 layers, and the nerves over on the right. A U-shaped cut through, coming from below. Professor Masakai Ito, he does a beautiful job. I'm going to rush it forward a bit. But you see here, this is Denonvilliers, and you can see there are at least 2 layers he seems to have there. And he's doing a very beautiful job. You have to be very, very good to have these planes perfectly from below. I think it's more difficult. I have the feeling you have to be very good indeed to do this quality of layer recognition and dissection plane selection, which is key. Let's consider Valdair's septum from below and above. Valdair runs from the front of the sacrum and low down tapers to fuse with the mesorectal fascia, it creating, in theory, 2 spaces. But of course, it's surgeons who make spaces. It's a sacromesorectal septum. And it's important because it gives you a safe inside fascial dissection plane and a less safe outside one. We've seen this before. Okay. We've seen this before, but I thought when I did it, I was in the holy plane. But if you look now, you can see that I was not. I will turn off the sound and explain to you that actually it's quite clear that we're in the outer plane and that you're looking at Valdair coming out on the specimen. Now that's all right, except that it's more dangerous outside. And there are veins which you can make bleed. Furthermore, it's more dangerous as you approach the nerves laterally, as we're doing here. We're going out towards the nerve. Now, if you're outside Valdair, you are going to have to find your way through it and clear of it to preserve the, in other words, you're going to have to taper inwards towards the mesorectal fat to make that mesorectal surface dissection and clear the nerves of potency and erection. This possibly could have been the end of my last TME, because I haven't done one during lockdown. I've been locked away in England. But this was with a German professor in Professor Markus Butler's unit in Heidelberg at the end of 2019. And I especially show you that picture in the middle because we have, you will see a curved line across the a curved line across the bottom of the picture, which is where we've cut through Valdair's septum. Important, because this was a fixed cancer, had to be cut off the sacrum, and so it looks a mess above the white arrow, but you can see the cut edge of Valdair. It's important to understand these things. Is it not better to dissect in front of Valdair, i.e. to leave it in the patient? Of course not if there's a cancer posteriorly, as in that last case I did. Coming from above, you'll see Amjad Parve teaching people in the European Academy in Lisbon. You see him very, very carefully dissecting in front of Valdair's septum. And you see the immense care with which he seems to be going so slowly. Festina lente, hurry slowly, because he can do the whole operation with perhaps 5 ml of blood loss. Coming from below, this is such an important, this is transanal TME, and it's an error trap for anyone thinking of doing it. And I have to say thank you to Greg Wynn from Colchester. What are we seeing there? We're seeing the white layer on the surface of the mesorectum, and we're outside it. So clever old Greg is realizing he's seen bare bone at the back, and he realizes he's too far out, so he's coming in. And there he is, coming in and finding the plane, which is safe because it's inside that layer. Very, very important video, this. And I make no apology for showing it again and again in my travels. I try to show it to as many people as possible because it shows the safe place to be transanally, and people have made terrible mistakes by not being. They've been led out. That's a catheter you're looking at. The surgeon's gone right round the prostate and cut the urethra. There's more than 50 cases in the literature about that. So if the mesorectum covered with Valdair's septum, take extra care and work your way in again to find the mesorectal fat and avoid damaging the nerves. Inside is safe. Coming from below, this is again Professor Ito, and I have to rush through here to get to the end because I'm running out of time. And you're seeing here, I think he's actually still outside. But I think it's more difficult to be quite sure. I think there at this point he's outside. So important business, Valdair and Denonvilliers at the front, Valdair at the back. This is so worthwhile to see what Amjad can do with the robot. It's exactly the same principle. The technique is slightly different. I already mentioned he talks of painting, and he thinks that he's using monopolar diathermy, and he's choosing carefully to go in front of Valdair. And you see the Valdair dropping back. We already showed it once, but you see the principle. He is sticking with the holy plane. One more post-radiotherapy case. You see the desmoplastic, edematous, fluid-laden tissue in the pelvis that he's stroking his way through. You will find that neither he nor I has much time for lymph nodes on the pelvic sidewall, just doing a perfect TME is probably almost all of what a rectal surgeon can and should do for rectal cancer. I know that's not agreed by everyone, but that's how he feels and I feel. So, one more thing, fat between the planes. Nowadays, with the robot, we tend to notice deposits of fat. Presacral fat is a common thing, and this is just fat randomly between the layers in the planes, confusing us. And in general, it's better to stick with that innermost proper plane if you can. This is where the holy plane finishes. It's a tailored intersphincteric abdominoperineal. You see the two buttocks, the perfect TME. But now, following that plane right down between the pubococcygeus muscles, the innermost layer of the overlapping muscular layers of the pelvic floor. And you see here that we are actually demonstrating, or Amjad is demonstrating very beautifully, the anal sphincter from above. And you're seeing puborectal sling is the next layer out, as it were, from the pubococcygeus, goes pubococcygeus, puborectal sling, and then the layers of the levators. And you see them all dropping back, and the visceral gut tube, that lowest end of the gut tube, which runs from mouth to anus, the same principles applying. And you see that actually our Valdair, which side of it are we? Difficult to be absolutely sure. Is there a bit of Valdair that we've now left on the specimen? It doesn't really matter. We've stayed in beautiful planes, but it does matter for finding your way to the right places. So I hope that the sacred, holy nature of the plane, I've succeeded in commending that to you. There is the skin, and actually it's my finger outside moving it around. That's the skin around the anal opening from above with the robot. Remarkable, isn't it? And it was a very satisfactory intersphincteric APE operation, but in a girl too. So that really is the holy plane, at least from the whole hindgut down to the anal skin. Of course, we haven't covered the abdominoperineal operation that goes further out. I'm sure that we should be thinking about accurate MRI and doing more of those intersphincteric APEs, like the last one, the end of the holy plane at the anus. But anyway, thank you for giving me that subject. I could probably go on for another 45 minutes very easily, and I certainly could go on for 45 minutes about APE. But thank you for having me. Thank you very much to the Sanadipan Foundation, and thank everyone for listening to me and watching.
That was a wonderful presentation by Professor Bill Heald, the creator of Holy Plane of Heald himself. Now I hand over the mic to Professor Mark Coleman to moderate the session.
Thank you very much, Professor Baiju. Bill, I've asked you this before, and when I talk about you to my junior colleagues and people that haven't met you before, I'm often asked the question, how did you come to develop the idea of total mesorectal excision in the Holy Plane at the beginning? What was the light bulb moment for you? Because for us, you know, we have a rare opportunity to hear from a person who has developed a groundbreaking revolutionary technique.
Well, I think that I tried with some of the earlier videos. Sadly, I've been watching the images that you've been getting, and there has been a technical problem. And before we go any further, I would promise anybody who has been kind enough to go on listening to the end of my presentation that we can give you the Vimeo link to watch those videos in real high definition. And I think it would be, if you're interested, it would be worthwhile, because they are good videos and an awful lot of detail was lost. And that's really my answer to the question, that I've always liked, I was a simple surgeon. I'd learned, I think, how to do a hernia nicely, how to do a few other operations nicely. And mostly the natural way to learn a nicer operation is to stay in an avascular plane, to use traction and counter traction. And the way I was taught to do the rectum was simply that one had never seen what on earth went on, because there were a few cuts with a pair of scissors, and then a hand was thrust in, and a big wrench, and when everything was on stretch, a pair of scissors cut laterally, and we were told those were the middle rectal arteries that were bleeding. Almost certainly they were actually intramesorectal arteries, because we were in fact doing completely inaccurate cuts and tears of tissues we were not seeing. But it gradually dawned upon me that if you looked carefully, you could find, I ask you please to click on the Vimeo that we're going to put on for you. We'll give you the link. And I think you'll see that the original inspiration was just, well, there is an avascular place to go. And if you follow that, instead of going down wherever the peritoneum takes you, you actually find that. Suddenly you realized there was a possibility of doing a nice operation without too much blood, a little blood here and there. There are little vessels where the area of adherence that we call the lateral ligament, but they only need a touch with the diathermy. So I think the answer was, this was an idea that just came from a practical surgeon looking for a nice place to, a nice plane, a dissectable space, if you like, between the layers. And of course, you can summarize the whole thing in the way that I used to. If you could do the whole rectal removal, seeing all the time where you cut and always cutting in the white, you will cure the cancer, unless nowadays your MRI has told you that that plane is breached by cancer. So I think it really was a surgeon's idea, and then of course we realized, why is it there? It is because the mesentery is really the organ. So the organ is not the rectum, it's the mesorectum within which the rectum develops. My early slides showed that. So it is logical that you should do your dissection between a midline structure with its midline blood supply from the front of the aorta and so on, and carefully and accurately separate it from the surrounding nerve plexuses and all of the things, the parietal tissues, all of the things which are paired, if you like. You know, we have two kidneys with arteries coming from the side of the aorta. Then we have the whole of the visceral tube from mouth to anus. Gosh, that was a long answer to your question, but I think it honestly was just a journeyman surgeon's idea, then realizing that it was based on embryology, and then trying to talk about embryological planes, and the innermost dissectable plane is a very good way of getting across to a young surgeon how to avoid damaging those nerves and at the same time to produce an optimal cancer specimen.
Thank
Sorry,
you.
I do talk too much.
It's a superb answer, superb answer. Just to put you on the spot, and heaven forbid if you've had rectal cancer, nowadays there are perhaps more techniques available to us than ever before, with robotics, laparoscopic, TATME, and of course, open, together all the adjunctive therapies as well. If you had a tumor, let's say involving breaching, threatening the CRM, whether it's tumor node or vascular invasion, you know, what treatment would you, where would you go? What treatment would you choose to have?
Well, I can only answer this question as the famous Cuthbert Dukes answered it long, long ago, before there was laparoscopy or transanal or anything. But I think the answer is still the same answer, and that's why I quote the great Cuthbert Dukes. Incidentally, you see a picture of John Gallagher there behind me there. But Cuthbert Dukes was the same generation as that, and he was asked what he would do, and he actually said, I would choose my surgeon very, very carefully, and then I would tell him to have an early night and not drink too much the night before. And I think, quite honestly, that's what I would do now. I think he should choose his method. And I don't really think you can yet find a surgeon who can do everything optimally and could deliver the same thing transanally as he could from above. Maybe you can. We don't know what's happened during lockdown, but we haven't been doing the cases as fast as we should have been in lockdown. We're horribly behind in Britain. And in Portugal, well, they mostly kept it going, but so I think it's the surgeon most of all. And if I picked a laparoscopic surgeon who didn't happen to have a robot, but did really beautiful surgery, I'd be very happy with him. And I'd have to say, some of the very beautiful surgery that I've seen with, you know, my friend Amjad Parve, who's now our colorectal boss in Lisbon. He will do a low anterior resection and anastomosis with maybe 5 ml of blood loss. You saw a little bit of that white dissection at the end. The red that I spilled in my open surgery, although I think the planes are perfect, and in some ways the teaching from those pictures, that's why I want you to go for the Vimeo, just to look at the detail a bit. But answer is, it's the surgeon that matters, and that's still true.
And last question from me, you know, you are still very much in the middle of your busy career, but if you had your time again, if you had your time again, Bill, would you do anything differently?
Funnily enough, no. No one's asked me that question. No, I was very lucky, really, because I could take as long as I liked. You see, I did treble the amount of time taken to do a rectal cancer. They used to do one in 3/4 of an hour when I started. A lot of wrenching and cutting, and a bit. The first one I ever saw done by a guy's hospital surgeon where I was a student. The patient bled to death on the table. So I thought, this is serious stuff. And touch wood, we've never quite had that happen. I don't know. I've enjoyed my life. I had a very good one, and a lot of very good friends like you, Mark, and my registrars.
Thanks.
Mark was once my registrar, and a jolly good registrar he was, as you can imagine. But no, I've been very lucky. I wouldn't change a thing.
Well, one thing you inspired me to do, because you went to a hospital which at the time was, it's fair to say, reasonably obscure and is now world famous, was sometimes going to a place that doesn't do something is an opportunity to do something. And then, of course, you appoint fantastic young colleagues like Rajesh.T.K, who then are teaching me a thing or two about precise dissection in the pelvis with his technique, which is exactly like painting, as described by Amjad Parvez. So with that, I'm going to say thanks again to Professor Bill Heald, my great hero, mentor, and friend. And I'm going to hand back to Rajesh.T.K for further questions, and back to Professor Baiju Senadipan with again my thanks to everybody for this wonderful opportunity. Thank you.
Yeah.
Thank you, Mark.
Yeah.
Thank you, Mark, for a wonderful moderating this session. And thank you, Professor Heald, for a wonderful enlightening session. I remember when I was doing anterior section 90, we go in that plane, what you describe as a pelvic rape. So which has been changed to beautiful surgery now. But we are now gadgets like laparoscopic, high definition videos, 4K videos, 3-dimensional videos, and robotic aspects to clearly visualize this plane. There are some few questions in the chat box. I would like to ask you, Professor. One question was, if the tumor is a T4 cancer anteriorly placed close to the prostate, how do you approach the de non-villus fascia?
Well, in that case, of course, I think you must carefully get yourself behind de non-villiers, as most people coming down from above see the white surface, in a man anyway, will see the white surface of de non-villiers, and it is easier to stay in front of it until you get to the point where it fuses with the back of the prostate, where you have to make that U-shaped incision in it, it has to be more a V than a U in a way, because the two neurovascular bundles are coming down together, tapering towards each other, of course, to end up in the root of the penis and to give you the power of erection. As far as the nasty tumor growing into the prostate, I think you have to stay. What did I say? Yes, I said you have to get behind it. I don't mean that at all. You have to stay in front of it, and then you have to either take a shave off the back of the prostate if your MRI indicates that that might be a sensible thing to do. You stay carefully in front of it. You identify the nerves on both sides. Try gently to ease them out of the way if you can. And then you don't make your your U-shaped, V-shaped incision. You stay in front of de non-villiers, and if necessary, very carefully, without damaging the urethra, perhaps take a shaving of the back of the prostate. Or you should have decided in advance from your MRI that you have to do an exenteration. But I actually mostly think that as shaving post-chemoradiotherapy, because you will have given such a case chemo and radiotherapy nowadays, you will have identified the threat to the prostate. And if you can get away with it, it's so much less an operation for the patient. And post-chemoradiotherapy, I would say the shaving off the back of the prostate, you may make the patient impotent, and you should certainly warn him of that possibility in such a case. But I'm not a great fan of pelvic exenteration. When we see a tumor which demands it, absolutely demands it, we tend to have just a handful of surgeons who tackle that case. And I've never really been one of those. I've tended to turn to one or two colleagues, and I expect you do the same, or are you into exenteration? One or two of you will be, I think, but I think it's a mistake for every surgeon to do exenterations.
Yeah, absolutely true, Professor. We discuss the MDT and we make a combined decision, and that's very, very important. And
Dr. Abhay we wanted. He is the President of the Surgeons of India. He wanted to comment something. Can you please unmute Dr. Abhay?
Yeah, I'm already unmuted. Thank you, sir, for a wonderful lecture. After 36 years as a staff on the medical college, it has been extremely clear as far as anatomy is concerned and the plane of holy dissection. On the behalf of the Association of Surgeons of India, thank you so much. On behalf of my medical college, also thank you so much. 2 or 3 things that I just want to ask you. Number one is, in your talk, repeatedly you talked of a midline organ. What is the importance of dissection around a midline organ? That's my first question to you. I've got another 2 ones if permitted by the authorities.
Please go ahead.
So, well, the importance of the midline organ, and I would suggest that the whole of the gastrointestinal tract is essentially a intricately refolded and extended tube which forms within a mesentery, which has midline blood vessels and lymphatic drainage, and that it is an integral block of tissue with all the lymphatic drainage and venous drainage contained within a fascial covered envelope or series of envelopes, the hindgut, if you like, and then each of the segments of the colon essentially has a mesocolon and the relevant blood supply. And I tried, although it didn't come over, unfortunately, on the Zoom, I tried to show that there's, even with a little imagination, a fascial covered top to the envelope that is produced by the fact that most of the body is paired with 2 legs, 2 kidneys, etc. And there are 2 hypergastric plexuses. Those are paired and they are separated from this midline visceral envelope, which is the principle behind the basic optimal cancer specimen for a surgeon to take out. The same principle really applies to the pancreas, the stomach, and it is the understanding of the way the colon has folded that enables us to understand the greater omentum and the fact that that has its blood supply from the greater curve of the stomach. And the colon and mesocolon have simply got stuck to the back of the greater omentum and stomach. But essentially that was folding, of course, in the course of embryology. And I think one of the excitements of being a surgeon, whichever way you do it, laparoscopically, robotically, open, you are learning exactly about how that midline organ with its plane around it, how that folded in, and it becomes particularly interesting at the ends. It's very interesting, for instance, in the neck and the throat, but you get down to the anus, there we have these 2 interesting extra layers that I talked about a lot. And then you have the insertion of a visceral midline internal sphincter, which is the lowermost of the midline tube inside the skeletal surround of the pubococcygeus muscles, the puborectal sling, and then the various layers of pelvic floor. They are all essentially double and paired. I think the whole nature of dissecting around gut cancers requires the same hypothesis, I believe. It's more than a hypothesis, it's an anatomical fact.
Sir, I thank you for clearing many doubts about the Wilder's fascia and the Denonville's fascia, that they are merely a septae. What is your advice to surgeons who are operating in this area? How does one go about identifying these two septae? From tomorrow, I'm going to call them septae and not fascia at all. Thank you for that.
Thank you very much.
I would for general surgeons, I would like to know, how do you go about identifying, because you showed wonderful videos how even experts can get into a wrong plane.
Well, I think most people in minimally invasive surgery, most people start with the at the top with the artery, but they then it varies where they get into the actual plane and find the shiny envelope. And I personally think the best place to start is, I showed it on a video which I was very disappointed in when I came to look at it on the Vimeo, the image that came back to me from India, as it were. It was disappointing. And so I'm sure it was for you too. But essentially, if you imagine lifting up the left colon and gently easing the gonadal vessels and the ureters, both paired non-midline structures, you're easing them laterally, and you gradually work your way through the areolar planes until you are seeing the shiny package. I think I showed a Romanian surgeon, Pescu, doing it with a hook laparoscopically, and finding this shiny core, and then just refusing to go anywhere except the holy plane. So you're lifting the organ forward, and you're opening by traction and counter traction a white plane, and the white plane will take you everywhere until you come across what are called the lateral ligament area. What about used to be called that. We're saying there is no ligament. It's simply, when you get there, your white plane tends to become adherent, so that the plane largely disappears, and 2 or 3 vessels, little vessels, will go through, and 1 or 2 nerves, sometimes quite big nerves, which of course are the autonomic nerves to the rectum. And when you get there, I think you will have to cut those because they're going through the mesorectum to the rectum. There you need traction gently on the hypogastric plexus and the nerve layer outwards, and traction medially and gently doing mesorectal surface dissection. The white plane has failed you there because it's adherent, and that's what caused the rectum to be tethered down into the pelvis and gave it the name of a lateral ligament, because when people were doing it with their hand, they found something was tethering it, so they cut what was tethering it, usually cutting into the mesorectum or perhaps damaging the nerves, or maybe both. I remember being in another country, not yours, where the professor asked me to come and say, he said, I think I'm a little lost. And he had actually managed both to cut and go into the mesorectum at the same time. You may think, well, that's very unlucky. He's anyway, I believe that there is an embryological plane there, and you can have a whole happy lifetime of following it. And I would suggest starting maybe 5-10 centimeters distal to the origin of the artery.
Sir, my last question to you is, for benefit of budding surgeons to know this proper plane, would cadaveric dissection be helpful?
Yes, it can, and has been most beautifully done by the cadaveric dissection has been done very beautifully by Professor Ayhan Kuzu from Ankara in Turkey. And he has, I think, his own method for fixing the human body. The normal cadaver that we get to dissect, the planes are sometimes a little disappointing, but he seems to manage to produce very nice cadaver specimens. And I'm not, I think he's a little secretive about how he manages to get such beautiful examples. But yes, it can be a very good way of learning these planes. You can always find them. It's not as easy. I mean, it's easiest in the young woman. I mean, I ended by showing you where the holy plane ends, which of course is where the internal sphincter, the bottom of the midline structure, is inserted into the puborectal sling. And there you go from white meat on the inside and red meat on the outside, and there is a lovely plane between the two. That's a young woman, and you will not see it quite as easily in the cadaver. But anyway, definitely worthwhile, because it isn't, you know, I suppose most of us learn these things on the job. And that is never quite ideal, is it? It's not the optimal.
So my college has been one of the first ones to train people in unembalmed cadavers with the facilities that we have. I think we can do this. It's nothing secretive that somebody has to be. It's definitely possible to get into these embryological planes. So last thing is, thank you very much, sir, for a very painstaking video that you made, accumulated so many videos from so many countries. As the president of Association of Surgeons of India, I have to thank Senadipan Foundation, both the moderators and 27,000 members of Association of Surgeons of India. This lecture of yours is going to go a long way in learning process of this holy plane. Thank you so much, sir.
Excuse me, may I somehow ask my technical colleague, Nick, who has been absolutely essential to me whenever I communicate with anybody else, but he can give you a Vimeo link. And apparently he tells me it's already been sent.
Yeah, it
so
is
that
circulated.
Anybody who wants that Vimeo link, I think it can get it from the foundation or from the association, I would suggest. It's a gift. It's a gift. And I think you will find it worthwhile to put it on your big screen, because there are carefully chosen videos, and I was rather disappointed in how well they traveled. But they will travel by Vimeo, no trouble.
Thank you so much for sharing the videos with us, sir. And before I give the mic to Dr. Rajesh, I let invite Dr. Joel Leroy, another stalwart in the field of colorectal surgery. Professor Joel Leroy, please, your comments.
Thank you. Thank you for your invitation to speak. I have a comment and question to Bill. First, I'm very happy to see he's always young. I know him and met him in '92 in Coimbra in Portugal. And I remember I presented to him one of my first coloanal anastomosis after TME by laparoscopy. And he watched all the movie and only did the comment when I was during the suture of the coloanal suture, saying it's exactly what I do. So I was very happy. And a few years later, in 2000, he was invited in Strasbourg and saw a live demonstration of TME. And he was not completely convinced before seeing a live demonstration. And this day he said, I'm convinced. And I remember I was very happy. And only to say, for me, Bill, you are, and it will be my question, the first video surgeon, because you were teaching all the technique using video, doing live demonstration with video, fantastic video, open with all the technology. You were very excited by the technology. And today, you see, I'm convinced that if TME is done worldwide very well, not well everywhere, but better and better, and it is due to the technology, the teaching by video, teaching by internet, teaching by what we do today, fantastic tools for teaching. I've seen a question to you. Is it how we can learn on a book? I will say it's not book now. It is training by video, by internet, by the meeting as Beju is doing and others, and it is fantastic. So my question, do you believe that all this technology is changing the manner of training and teaching? Your lecture was fantastic. It's a fantastic remember of what I think I have understood. And I want to know your opinion concerning the new manner of teaching and training.
My dear friend Joel, and he is a very dear friend because we were fellow travelers, and I would be most proud to think that I had helped him a little, because the success of laparoscopy throughout the world, minimally invasive surgery, was led by that man. Joel is the man who said, well, he liked the ideas that I've tried to convey today, and that he would do it all minimally invasively. And it took some years, but he did it. And he has been the greatest teacher of laparoscopic surgery in the world. So to have him give the thank you to me is a wonderful compliment. And I thank the association and the foundation for having Joel there. There is absolutely no doubt that the biggest single advantage of minimally invasive surgery is that if someone like Joel does a beautiful operation, instead of just one person peering over a retractor into a wound to see it, maybe hundreds of people will say what Lars Polman said about one of my early videos, which was, aha, that's the right way to do it. And that really, the great advance from minimally invasive surgery is maybe some advantage in technique, but really it's the advantage of being able to teach many people from one good operation. And the man in the whole world who has done that most is Joel. So what an honor to have you speaking about me, Joel. Thank you.
Thank you, Professor Joel Leroy, for joining us.
I want to say, I want to remember to Bill with our friend Gerald Marx. You have Mr. Mezo, and he said, I'm Mr. Lapo.
Yes, that's right. Yes.
You remember?
I was Mizo and you were Lapo. And, and then there's somebody we call Eno, I think.
Thank you, Professor Leroy, for joining with us.
No, it's my pleasure.
Over to Rajesh for taking the other questions.
Professor, the one question, interesting question was, somebody has asked, your name is R.J.Heald. How did you come, they call you as Bill rather than Heald?
This is the fault of my grandfather, because when I arrived and he first saw me, he called me Little Willie. And so the William is long for Bill, and somehow I acquired the nickname of Bill. And I have been called Bill ever since. But this causes endless confusion with computers, passports, and all of those things. But I am really Richard John Heald, but everyone calls me Bill. So I think I am Bill Heald to surgery anyway.
Initially, we were confused, actually.
That clears most of the doubt for many of the people. And the next thing is, when we come to Pelican Foundation, you give a video of all the techniques from imaging to the open, to the laparoscopic, to the robotic. So those videos, is the videos available in Amazon or somewhere to buy for the Indian surgeons to view?
Well, let me say that we've been in lockdown now for a year and a half on and off. And Brendan Moran, who you may have heard of, who is the man responsible as for the peritoneal surface malignancy unit, which has actually done more pseudomyxoma peritonei operations than anyone else in the world, approaching 3,000 cases now of cytoreduction and all of that. He and I are starting a series of what we call Tea with Bill and Brendan. You know how we English have a cup of tea in the afternoon. I think you Indians do too, rather, tend to have a cup of tea in the afternoon. So we thought we would start, and I'm afraid we've been slow off the starting block, but if you would go for, maybe it will ask Nick how they can access it. But every month we are going to have a guest. I hope we can lure Joel one of these weekends when he comes to Europe. Maybe he would get in touch with me. But we will have a guest, if necessary, in the early months, a remote guest to tackle a particular subject. And every month come for virtual tea with Bill and Brendan. In fact, talking of tea, I have to say that I had a cousin who grew tea in Kerala after he survived World War II. He went with his young wife to Kerala and was a tea planter. So, you know, we all drink our cup of Indian tea in the afternoon. And whether you can actually be with us or come only by remote means, we would like to teach you some subject every month. And access is really via the websites of the Champalamo Foundation, of which I showed you pictures, where my principal job now in my old age is to be chairman of the colorectal cancer project, or the Pelican Cancer Foundation in the UK. And so you should be able to access all the videos that we will gradually build into an organizable library. That is our big project this very month, to get that really started. So we would love to share videos with you. I've started with one this very day. Sorry?
I can follow you on Twitter.
Apparently, you can follow me on Twitter. I have never actually willingly accessed Twitter, but I do have a PA, a personal assistant, who tells me that I should be taking more notice of Twitter. So apparently you would be able to access these monthly tea parties with Brendan and me by going via Twitter.
Thank you, Professor. Before Rajesh, Dr. Thomas Varghese has put some doubts in chat box. Dr. Thomas Varghese, can you please unmute?
Sure, I am unmuted.
Yeah, please.
Dr. Heald, I am really thankful to you for this wonderful lecture. I'm from Kerala, from where you're telling about the tea, from the same state. I have got two questions to you. Am I audible?
Yeah, you are audible.
Yes, yes.
The number one is, you told it is better to give neoadjuvant chemotherapy rather than chemoradiation if you are planning for downstaging. So,
well, yeah. I'm very interested in the complete response.
yes.
You remember I showed one of my really favorite patients, who is 13 years after she was given chemoradiotherapy for an advanced T4 lesion with N2, penetrated mesorectal fascia. And when I arrived, I was invited to go and do it because the surgeon was worried about whether it would be possible. And I drove 4 hours. And when I got there, I could not feel the tumor. So I am very keen on the idea that the bad tumor, particularly the one where the mesorectal fascia is penetrated by cancer, I think such a tumor should have preoperative chemo and radiotherapy. We can argue hugely about the detail, but I mentioned Rapido, and Rapido is you can get the study. It was only, I think, around September that it got into print. It came from Stockholm, from the Karolinska Institute. A number of friends there I have, and I've followed this over the years. But I would suggest reading that because it does suggest that the 5x5 short course radiotherapy is followed by, you see, we used to do the operation immediately after 5x5 radiotherapy. In fact, they even suggested we should do it on the Monday after the patient had finished the radiotherapy the previous week. Well, that leaves no time for the tumor to downsize and no time at all for it to disappear altogether, which we now know can occur. So that what Rapido is giving us is a respectable protocol for doing all the radiotherapy in 1 week and following it by a certain number of cycles of chemotherapy and then operating maybe 2 months or 3 months later.
Absolutely.
And such a patient such a patient, if they should, like that beautiful girl I showed you, who's having such a great life, probably better than if any of us had operated on her for this awful tumor, I think we should keep an eye out, because I'm a surgeon, I love operating, but I do not like to operate on somebody and then get a report from the pathologist that they could find no cancer. You can take some consolation, if you like, by the fact that it might regrow later. But the reality is, if you get a report back which says no cancer after chemoradiotherapy, that probably that will not would not have regrown. So I think there is I'm keen on radiotherapy only for the advanced case. I am unhappy about the current trend towards irradiate the Star Trek and Trek trial. There's this month a Trek trial sort of intermediate report, but it'll be 10 years before we know whether it is safe to irradiate T2 lesions and then do little local excisions. I think it's a big subject and a different subject, but in principle, I believe that some patients, probably about half, can be operated upon straight away, most particularly because the mesorectal plane has not been penetrated by cancer. But the ones where it has been penetrated, and perhaps certain others, like those with cancer in the veins, visible on the MR, so those should probably also have preoperative chemo and radiotherapy. And Rapido suggests that this does not necessarily have to take 6 weeks of small doses, that you can probably do the radiation in 5 days and then give chemo. This would make it more practical, particularly in India. I think even in any of our countries, giving 6 weeks of chemoradiotherapy is quite demanding for the patient and very expensive. It will never be very well sold as an idea in America, I think. It'll take a long time. But in Europe, I think most people will move gradually to short course. Sorry, it's a long answer, but let's face it, we could have a whole 2-day meeting on this subject easily.
The reason why I asked the question is there are good cancers in the rectal region and bad cancers. It all depends upon the tumor biology. There are some cancers who will respond very well to chemotherapeutic drugs alone and no need of radiation in those cases. So it's very essential to distinguish who requires what before we embark that everybody should receive chemo-RT. Wherever you see a locally advanced tumor, that locally advanced by virtue of just definition doesn't mean that locally advanced is locally advanced everywhere. It could be anterior, posterior, lateral, or it differs from the location. So my point is tumor biology decides. So therefore, with the advent of modern drugs in chemotherapeutic regimens, everyone need not get chemo-RT upfront. There are patients who will benefit from chemotherapy alone upfront, so that we'll know how to add radiation later and how much clarity you get it. So that looks like many studies are showing upfront chemo alone rather than chemo-RT in selected cases.
Well, this is under study. It's being studied, and it is, as I say, we could very easily have a very long meeting about the use of chemo and the use of radiotherapy. I don't think that unsays anything that I've said. I think that some tumors are different from others, and so far we, despite sequencing and so on, we are having difficulty in predicting which tumors will behave in which way. And there are studies. You've made a statement, I would not disagree with it. But I still think there is a group of people who, if you do a perfect TME and you don't damage the nerves, they can be done without chemo and radiotherapy. And then the worst tumors, certainly you need the chemo and radiotherapy. And there are many questions, some of which you have answered.
Last question. Any indication where you find the denominal fascia is invaded to have a radical prostatectomy combined with anterior resection?
Yes, that's a very difficult. That's a very difficult one to answer. I suggest you direct it to Joël Leroy, because he is a bit of an expert on this area. It is, of course, possible to do this operation. It's quite challenging. And I personally have only some experience, usually satisfactory, of taking a slice off the back and leaving the urethra uninvolved.
The reason why I asked the question is, in the robotic era, we are doing prostatectomy with absolute precision. And if a local recurrence by virtue of anterior extension to the prostate can be avoided and patients get 100% local control, why not think in that direction?
I'm not going to disagree. Thank you. I haven't anything to add.
Thank you. Thank you, sir.
Oh, thank you.
Rajesh, there are some more questions in the chat box. Can you please take that questions?
Okay. So some of the questions which there in the chat box was, Professor, when you're doing APR, at what level do you stop abdominal dissection, and when you will do the perineal dissection? At what level? That is one of the questions. Can you answer?
Well, yes. As I already showed you an intersphincteric APE, I do think that MRI assessment of the detail of a very low cancer is even more important than other cancers. And it does enable us to make each abdominoperineal like a tailored procedure for a given cancer. But if we take the standard one, then I personally have changed in my lifetime to preferring to turn the patient onto his face or her face for the perineal dissection. So, in fact, the question you ask is absolutely critical, because it is how far down do you go before you turn the patient over. And this is will be for, in general, quite bad cancers that are invading the musculature of the pelvic floor to some extent. And the answer is, I would try to identify laterally the what I call the arrogant pillars, those areas where you saw me carefully doing the mesorectal surface dissection. At the front, you would cut through Denonvillier's septum beyond the cancer if you could. It would depend, it depends so much where the tumor is threatening the tapering margin. And then I'm an extra levator APE man from below. I would dissect around the outside of the levator, take a part of the coccyx, a small part, and complete the operation from below. But it is a big subject, and I believe it's not an operation that we have in general done very well, most of us. And I'm sure that was true of me in my early years. I think we did rather disappointing operations in which there was not as much precision as there could be. I think the perfect abdominoperineal operation is a perfect TME with a levator wrap up to the point where the levators are attached to the pelvic sidewall, and that is just beyond where the nerves are. So I think the perfect TME specimen, sorry, the perfect APE specimen does not have the bottom part of the TME plane developed. It actually is wrapped in the levator muscles. But it is a whole subject in itself, which could go on for quite a long time. And I would be against doing that unless it was necessary, because it is quite a big operation and it can leave a space. It's a big subject.
Yeah, agree, Professor, agree. It's very, very important. And I think we have covered most of the questions from the chat box. Anything else do you see, Baiju?
Not really. One question was there from Madhu Murali. Actually, he has left. I was searching him here. He was asking about the abdominal part.
And there is also a question about high ligation of IMA and low ligation of IMA. Anything to clarify? Do you do high ligation or low ligation?
Well, I always do a high ligation and mobilize the splenic flexure as my standard operation. I think that this does vary a little bit. I mean, for instance, in Africa, you will get a number of people with very long sigmoids, which are perfectly reasonable. It's a little bit of a surgical judgment, and it does vary a little according to the build of the patient and so on. But I think the standard rectal cancer operation involves a high ligation, a mobilization of the splenic flexure. But I have no objection to the idea of ligating the IMA beyond the takeoff point of the left colic artery, the ascending left colic, in selected cases. But I think you must be very careful. I have had a sigmoid colon die on me when I thought it was so that 2 weeks later you had some dead gut in the pelvis. So if you do preserve the left colic and a lot of sigmoid to take down, it's watch the patient very carefully and be prepared to go back and mobilize the splenic flexure. The standard one is the high ligation.
That's true. I also do the high ligation. One of the questions asked from our British forum is the results which you have produced in your unit is not reproduced by any other unit in UK. Could you tell us what is the reason and how can we improve the results as what you produced and what we should do to reproduce the same results?
I think I've been trying to do that but having some difficulty with the quality of the transmission of the images, which is why I want you to take that link and have a look and come to our tea parties, and we will continue to struggle to try to teach, but we will also continue to try to get better ourselves at nerve preservation and cure. We are far from perfection in rectal cancer surgery. We have a long way to go. You know, we still have to solve the problem of anastomotic leakage. And there is, watch this space, except I may not be here that much longer. Others, watch Joel. I think you should stay in touch with him. And well, Mark, all excellent people doing excellent teaching. Yeah. Minimally invasive surgery, hugely advantageous because of the way you can teach it. You can teach these same ideas much more easily than I could, mounting cameras on the lights in the open surgery cases.
Rajesh,
So,
regarding how will you tackle, if at all, there is a pre-sacral bleeding?
sorry, I missed the question slightly.
How will you tackle a pre-sacral bleeding?
Pre-sacral bleeding. Well, start by getting some more of my videos. If you it may not be possible to avoid that occasionally if the tumor is stuck to the sacrum. That is one problem. But assuming you've done an MRI and you do not have a local problem with cancer very close to the sacrum, then I think that the key is to stay in front of Valde's fascia. As indeed I showed you Amjad Parve with a robot carefully leaving Valder on the sacrum, because all those veins, the ones with no valves that bleed, and once upon a time we used to take drawing pins and push them into the sacrum, that will never happen if you stay in the holy plane. So it's only permissible to get pre-sacral bleeding if you have a posterior tumor which is fixed. You don't even need MRI to know which ones are dangerous. If you can't move that tumor on the sacrum, then the answer is it is a problem. And like all bleeding, the first immediate action, the first IA, is to pack it and do some other part of the operation. And with a bit of luck, when you go back, it's stopped. But essentially, stay in the holy plane and you won't have pre-sacral bleeding.
Exactly. Rajesh, any other question from the chat box? I think it's high time to wind up. Right?
Yeah, I think it's a brilliant session, and there is, I think we have cleared almost all the questions, and I think there is a Vimeo link has also come, and everyone can watch those videos. Back to Baiju. Thanks for the wonderful session.
Thank you, Dr. Rajesh. From this video of Prof.R.Heald, we can see that how passionate he is in teaching. Actually, he is so enthusiastic to teach even more and more. And his video is definitely going to help us and the next generation also. I thank you, Professor Heald, for blessing us with this wonderful opportunity for us to watch you live, virtually. And I thank your foundation and all your colleagues, and Mr. Nick also, for arranging this webinar and cooperating with the Senadipin Education Foundation, and Professor Leroy for joining the forum for discussion, and Mark Coleman, if he is there, I request him to give the concluding remarks, and Dr. Rajesh and all the participants, Dr. Abed Alvi, for your valuable contributions, and I request Dr. Mark Coleman to give the concluding remarks.
Well, thank you very much, Professor Baiju, Rajesh, my friend and colleague. And you know, I have to say, I have heard Professor Bill Heald give a talk along similar lines for 3 decades, and every single time it is enlightening, illuminating, and entertaining, and I always learn something new, and that is an incredible thing for a gentleman who's been in this game for so long. His enthusiasm is still an outstanding example to us all, and we thank you from the bottom of our hearts, and he's going to be around a lot longer for us to enjoy his company, and I'm looking forward to him coming back down to Devon and me coming up to Hampshire, and us maybe even traveling again together, Bill, which is something that we enjoy doing. We've been on a few trips and it's been great fun. Also, thanks to Joël, who I've met, and I've been to Strasbourg, and what a fantastic institute that is. And we all look forward to meeting and shaking hands and having a drink in better times. So thank you very, very much indeed.
Thank you, one and all, and Professor Heald, once again, thank you for your blessings. Thank you for joining us. Thank you for the opportunity to watch you. Thank you for your videos. Thank you for links and tweets, and thank you for your all the videos of even robotic, even laparoscopic, and your videos also. Thank you all.
Bye. Thank you.
Thank you. Thank you. Let us wind up.
All be safe from Corona.
Yeah.